welcome to this afternoon's conversation. I'm Kirsten England. I'm one of the other trustees of Nesta. I'm also the chief executive of the fourth largest metropolitan authority in the country, that's Bradford. And I both sit on its health and wellbeing board and I chair its system leadership board of providers and commissioners for health and care. Within Nesta, I'm directly involved with the work of Halima and the Health Lab. And so I'm absolutely delighted to be here and to host this afternoon's session. Now, it seems to me that today, in all our debates, whether we've been talking about technology or data and evidence, random control trials, whether we've been talking about systems or policy, we've actually always rooted back helpfully to a conversation which is about the people-powered nature of how we secure health and well-being. And very specifically, we've been talking about how we increase the agency and effectiveness of us all who are invested in securing health and well-being, which is us all because it's about our health directly or the health of others that we are committed to securing, whether as carers, volunteers, clinicians and researchers. And we've been having some lively debates through all of that I think are going to recur in this afternoon's session about some of the balances in that system of agency between, if you like, the state, the regulators, the professionals, the experts, and actually the people at the heart of all this, which is their health and well-being. And what are the right balances to strike? And what are some of the tensions, and how do we manage those tensions? I was actively managing them yesterday at our Health and Wellbeing Board, where we were looking at the latest output of the Marmot indicators for Bradford, and I was stuck in a rather vigorous debate between an opposition councillor who is a libertarian, who thinks any activity, possibly such as David might advocate, is the action of the not-so-paternalistic state, of the nanny fuss bucket type state, and my director of public health, who, quite frankly, if a sugar tax isn't introduced soon, is going to personally go in guerrilla style and put stickers on every packet of sugar and biscuits in every supermarket in the district, so concerned is she about obesity. And as is the way of these things now, there was commentary by Twitter, and at one point the opposition member tweeted, "I must be nicer to the people who work in public health." So these tensions, these debates are playing out. They're real. They're for now, as we all seek to craft strategies which will enable us to secure our and our community's health and well-being. And we're going to turn our attentions now very specifically to behavioural insights and their application, and also to work around peer self-help and support. And I expect many in the audience have had attempts, I certainly have, at applying all of these principles. So I'm absolutely looking forward to hearing from two people who have researched, thought and acted in that space at length. And so without further ado, I'm going to introduce David Halpern, who is, is Chief Executive of the Behavioural Insights team. And he's going to take about 5 to 10 minutes to talk about the work of his team, which I have to say Nesta has an interest in, having acquired an interest in the Behavioural Insights team a number of years ago. And actually, I'm happy to waive your book if you want. We did have a debate about who was going to waive the book, but this is an unashamed plug for David's work, because he said, I only have 5 minutes, therefore I really need you to plug this. This is the opportunity for people to know deeply and understand what goes on inside the nudge unit. So without further ado, David, come to the floor.
Thank you. Thanks very much. Okay, so I'm not going to do slides today, which is very unusual since we normally have loads and loads of material, but I'm going to whip through some examples about our work. It reminds me years ago when I used to be a respectable academic, at Cambridge, and one of the favourite recurrent essays was "My health is my doctor's problem, discuss," basically. I mean, it's kind of a good relevant question then, and it still is now. Is that really plausible in a world where we know that perhaps half, maybe 3/4 of years of healthy life lost to behavioural factors, smoking, drinking, diet, etc. And yet that's not where we put a lot of our focus, and certainly not our expenditure. Well, why not? And what can we do about it? I know Simon will be talking about that this morning. So the Behavioural Insights team, which is, indeed now part owned by Nesta, has done this in many areas, trying to introduce a more realistic model of human behaviour into policy, and to get people back to work faster, to get people to pay their taxes on time, all kinds of wonderful things. And of course, health. Health was always a big area. The other thing, I won't dwell on it, but you'll notice a key characteristic of our behaviour, and I think if you're going to do work in this area, is we've been very experimental, very empirical. So often it's difficult to know how real human beings will in fact respond. So we don't have to say we know the answer. It's possible to test variations. So, for example, testing variations on the Smoking Quit website. Why do we think we'll have the best design? Well, we didn't. So we tested 27 different variations to see, well, which was more effective to help people quit. And it matters a lot. It even matters through the time of the day, by the way. So simpler websites work better in the morning, for example, than in the afternoon. Testimonials work really well. But we can test this and we can build it around how real human beings respond. Let me just kind of quickly go through 3 areas anyway. One about patients, one about clinicians, and something a bit broader about social movements. So if we're serious about this, we should build, of course, our healthcare systems around humans, around real people, and how they make decisions. And there can be quite small details, as in other areas, that turn out to be really consequential. I'll just give you some examples. For those who know our work, it's very practical sort of stuff which you can use straight away. So if you want to reduce missed appointments, what can you do about it? Well, if you're going to send people a vaccination letter, it turns out if you have a little bit on the top which says you might want to write down the time and the day you're going to do this, makes much more likely that people will turn up. Even if they themselves do it, it's just on the letter as an extra little box. Or inside the NHS, we run trials where we've been able to reduce missed appointments by more than 25% by just varying the text that people get, just to remind them. Let us know if you can't make it. By the way, a good idea. Just give the phone number they might call, a good start. But otherwise, what kind of wording? Is it effective to say, it's really, please let us know, 'cause, to be fair to other people? Actually, that doesn't make much difference at all. On the other hand, if you just say, please let us know because this costs £160 if you can't make this appointment, leads to a very significant reduction in missed appointments. By the way, the worst thing often you can do is don't cancel on them. If you cancel on people, they'll cancel on you subsequently. Real human beings work like that. Or in terms of discharge rates, which a lot of us worry about, people returning back into a hospital, a clinical setting. Turns out often, we know from RED, a well-known program in the US now, quite often people aren't in the state to listen to detailed instructions at that point. And they are afraid to say to the clinician, sorry, could you slow down? Can you tell me a better way? What did you say? What did you mean by that? Having an iPad, essentially, which is explaining it to you, can lead to nearly a third reduction in readmissions at 28 days. Right? And not necessarily an expensive intervention. So the 101 is let's design our health systems for human beings, user-centered design, you might think of it. And I can see some people in the audience know lots about that. Hey, it turns out clinicians are also human beings, subject to the same biases and effects, and we should think about that too. Some well established, for example, the use of checklists in order to give people simple steer, clinicians simple steers to help work their way through in busy environments what might be more or less effective. Patient charts. Again, who'd know it? Doctors have really bad handwriting and other people can't read it. And if you redesign patient charts, you can dramatically reduce the number of errors that are made by using simple tick boxes. So you can tell the difference between whether someone had written milligrams or micrograms, and that's a 1,000-fold difference. So again, design it in a very simple way. Why is it that every hospital has a different patient chart, right? I mean, really, why? Using feedback relative to others, even to clinicians. I can't tell you the detail of this because we're going to release it, I think, next week in The Lancet, but a very nice study giving clinicians detail about their practice relative to other clinicians, leading to a significant shift in their prescribing behaviour. Really dramatic effect, one which is persistent over a good 6 months. So it's very, very strong. So look out for that. Or even helping clinicians, again, deal with other human beings, the patients. I mean, Simon, I talked about obesity, a lot of us thinking about that at the moment. A lot of clinicians are nervous about having certain conversations with their patients. Like, actually you might have a weight issue. A lot very, very worried about raising this. It turns out in a beautiful trial by Susan Jebb, where they actually did a trial to see if a clinician does raise it, well, how many people do object? About 1 in 500. Right? People are actually okay about raising it, particularly if you word it well. You don't normally say, would you like to go on a weight loss program? That doesn't work very well, because the answer probably is no. But you can, other wordings about you might want to consider this can be very effective. So clinicians as human beings, and there's a lot that we can do in that space, not least in between, in terms of, for example, if a result comes back, what's the feedback that goes also directly to the patient to help them inform their behaviour? I mean, we know perfectly well in other domains, if you give feedback to people that tells them about their energy use relative to other more efficient neighbours, it affects their behaviour greatly. So why wouldn't it be that certain clinical tests are also going directly to patients in a way that informs them about how's your blood pressure compared to other people, and here's simple actions you might take to do something about it, as opposed to only the clinical route. But otherwise, and I know you're going to talk more about this in a minute also, in terms of more as a social movement. So again, Simon, I think, talked a bit about obesity. We're all thinking about obesity, as I said at the moment. Fattest Europeans, whoa, well done, Brits. What are we going to do about that? And one of the fascinating things about the whole obesity area is that we ourselves are often unaware of what it is that drives our own behaviour, which makes it very difficult politically too, right? So we're not aware of what drives how much we eat. We're not aware quite of the force of how big our plate is, or how big the package is, or the fact that if we bring the crisp with us when we're watching TV, they all magically disappear. In fact, the effects are so powerful. An illustration of it is that even the very statistics that we use for how much people eat look like they can't be true. If you look at metabolic consumption rates in terms of how many calories people need to eat, and what is reported in the official statistics, we don't eat enough calories. So what's going on? It's because literally, even in our official statistics, they often rely on people reporting how much they eat, and people are literally not aware of what they eat. They just don't notice the extra Mars bar, cupcake, whatever, that happened in the afternoon. Incidentally, they get less and less accurate in their recall the larger they become, and we're all getting larger, as we've noticed. So what could we do about this? And I personally am quite optimistic about what can be done, partly if we can connect it to a sort of social movement as well. So an interesting question alongside the main part of the obesity strategy will be, what does a social movement look and feel like in this space? So it doesn't need very many consumers to shift to change the market too. So for those who know OneSync's work about what kind of aspects of an environment affect how much we eat in a canteen or anything else, it's not that difficult to think of designing a scale that consumers themselves can use to rate how much is this supermarket. There's not much loyalty to supermarkets, it turns out, for consumers. How much does it prompt me to eat healthily or not? What's at the end of the aisles? What's by the checkouts, etc.? What are the prompts? So that other consumers at the margin can choose a healthier prompting supermarket, right? You can imagine using these kind of tools and mobilizing not very many people to make other consumers shift their behavior a little at the margins, which drives product reformulation, restocking decision, and change the nature of what is being stocked and sold to us. I actually think there is a lot of things that can be done very powerfully in this space, probably not directly by government, but you want at arm's length that can be extraordinarily powerful to reshape markets. Are there lots of other things? I think you're going to talk more about it in relation to chronic conditions and how other patients can help each other. But let me just conclude with one point, which I've always felt we really neglect in relation to sort of human beings and healthcare, which is that people have a very strong desire to reciprocate. If you help someone, they will often want to help you back, right? If someone gives you a loan, you'll want to reciprocate, not necessarily in exactly the same way. And so in, of course, public service context in general, but health in particular, you're often in a context where you have helped someone, right? We are very poor at making an ask back of someone. We know there are systems in the world that do that somewhat better. So you might say to someone, we're so pleased you're better, etc., etc. Would you be interested in helping someone else? Or, of course, you might say the same to a relative. The King's Hospital, I think, is a great example now spreading of the use of volunteers. That's, of course, both young people who want some work experience, but often it's people who've been through a healthcare setting too. So people have this desire to reciprocate, and we don't utilize it. So it's just really trying to get the kind of discussion going. But I remain actually quite upbeat about what we can do, not just in terms of the underlying etiology and what we know on the behavioural side, but right from the nuts and bolts of how we design a healthcare system to make it more for humans, or indeed clinicians, but also our capacity potentially to harness social movements in relation to chronic conditions and indeed consumers to mobilise outside the healthcare setting can really make a huge difference if we're canny about it. So why don't I end there, and looking forward to hearing your comments too.
Thank you very much for opening up the discussion now. Without further ado, I'm going to pass across to Professor Edwin Fisher, who's the Global Director of Peers for Progress, promoting peer support for innovation in health and care and preventative work. just so you know, I started my first employed job was as a parent advocacy worker supporting self-help groups in Greater Manchester, actually, and particularly bereaved parents. And so I've witnessed some of the parents, some of the conditions for some of this stuff to work. So I'm really looking forward to hearing what you're going to say. So welcome to to Edwin. Sorry.
Thank you. Thank you very much. It's a pleasure to be here, and I really want to thank Halima and the Nesta team for their hospitality and for inviting me and the opportunity. I've been a great admirer of David's and the Behavioral Innovations team's work for a long time. I'm trained as a behaviorist in clinical psychology. David is trained as a social psychologist, but he became a behaviorist, and I did my dissertation in social psychology, so it's all mixed up. And by the way, David, I want to point out that one of the reasons why the calorie reports and the calorie intakes don't match is because if somebody else gives you the food, then it has no calories, so you're all free this afternoon. Also, if it's liquid, it has no calories. That's one of the other. I want to plug our own stuff, and this is free. These are a couple of blurbs on Peers for Progress, which are available on the Nesta table out in the snack lounge. So I hope you'll all pick up one so I don't have to carry them all the way back to the States. So I want to talk about peer support very quickly, and then some more general ideas that have sort of surfaced during the day. This slide is the most important slide on my computer. You probably all have seen the picture on the left. Harry Harlow showed that although people thought in the 1950s that the basis for the connection between the infant and the mother was that the mother was the source of milk, Harlow showed that except when it's hungry, the little baby went to the relatively warmer terry cloth mother on the left. From this and a whole bunch of other studies that he did very inventively, he made the point that contact comfort, as he put it, or the attachment to the mother, was fundamental and a powerful force in primates. So you've heard about the books, Men Are From Mars and Women Are From Venus, and similar nonsense. It's important when we talk about social connections and social influences to recognize we're not talking about a frivolous influence on the fringes. We're talking about a powerful, fundamental characteristic of primates, which includes all of us in the room, that we are reinforced, we are inclined to seek out conspecifics, people like ourselves, and gain support and succorance from them. And a whole lot of research bears this out, thousands of studies showing that if you have somebody that you can call on for a favor, who knows you, who understands you, you do better, whether it's trying to raise an adolescent child or trying to pay your taxes on time or trying to care for an aging parent or manage your own diabetes. The risk of death associated with social isolation, with the lack of social contact, is comparable to that from smoking cigarettes. So we are talking about a major characteristic of healthcare. It can be very powerful in our behavior, in our health behavior, if we harness it well. If we turf it to the volunteers on Saturday afternoon who can do no harm, but we don't really expect them to accomplish much, we will not do it well. If we take it seriously, we can have real impacts. Here's an example of a peer support program in Anhui province in China. Older adults were trained to co-lead a monthly group for people with diabetes with nursing staff from community health centers. They then also ran a separate meeting each month for people to just come and discuss what their questions and concerns and their progress were. They also led a lot of informal activities. The gentleman on the right is a farmer who now lives in the 6 million population city of Hefei as part of the urbanization of the Chinese population. He runs a walking group, still keeping farmers' hours, at 5:30 every morning. The gentleman in the middle is a retired teacher who runs a Tai Chi group every day. And this resulted in improvements in diabetes status. So this is just an example of the kinds of things we mean by peer support. To summarize what we've learned from peer support, what we've learned is that we can reach populations with peer supporters. In one study in Chicago, in a community health center for low-income Latino adults with diabetes, peer supporters were able to reach about 85% of 3,787 people with diabetes the clinic served. So we can reach populations. More important, we can reach those that too often are hardly reached. 90% of mothers of children with asthma who had been hospitalized for their asthma in a study in St. Louis. In other studies, our colleagues have shown that people who are initially low on medication adherence or low on health literacy actually show a greater differential response to the peer support intervention than others. So peer support seems to be a good strategy for reaching those we too often fail to reach. We also can reduce psychological distress, improve quality of life with peer support. Even programs not designed to address those endpoints tend to have a beneficial effect, and along with that, reduce the hospitalizations that so often accompany that kind of distress. So there are a lot of ways in which peer support seems to be a very robust strategy. It's certainly not a magic answer, but it seems to be a very robust strategy for addressing many of the things that we're concerned about in improving our healthcare systems. I want to switch and talk a little bit about methods and then general concepts. In terms of methods, I'm sorry, Halima, I didn't get this on the automated polling, but here's a question for you all. What do Copernicus, Darwin, Watson and Crick, and Einstein have in common? No control groups. Yet they're all well-respected scientists. So we've talked a lot off and on about methods today, and I just want to put in my plug that we need diverse methods of answering, methods that are well-suited to the questions being answered rather than imported from drug trials and applied uncritically in areas where they don't fit. This is a study of genetics related to breast cancer prognosis. And I think you can see to the left of this white line, that's a poor prognosis signature. To the right of the white line is a good prognosis signature, and that's a very fancy gene array. The point is, there is no single necessary and sufficient cause in all of that. Some genes are red and some genes are green for each of the people with good and bad prognoses. So what we're talking about, this is, the genetic revolution. This is high science. What we're talking about is a configural, multidimensional relationship between important endpoints and a whole lot of markers. And as we think about complex communities, maybe we begin to think, and maybe some of the ideas from the big data earlier can help us with this, think about how these kinds of things may be models for how we think of the very complex interplays in communities and families and social networks that influence our health. Sort of along those lines, I want to make a couple of general comments that I sort of abstracted from the day. First is that context trumps content. I think this was a main point of the discussion of sustainability earlier today, but I was remarked in Nick Dixon's presentation from Stockport this morning. It wasn't that they had an intervention. They got all the interveners working together. They almost didn't care what the interveners were doing. They had to follow some general principles. But the context of the interveners working together trumped the content of what the individual interveners were doing. Structure and incentives and choices trump messaging. If we don't have structures in place, if we don't have choices in place, if we don't have incentives in place to encourage the kinds of behavior we want to encourage, then messaging is unlikely to be the answer to our problems. Finally, I want to close by just suggesting some ideas that have emerged during the day and also at a dinner we were fortunate to have last night. There's the old model on the left and the new model on the left, on the right, they're really worldviews. The old model is illness as a micro event, discrete, individual level. And the new model is health as a macro, complex, and social set of events. So we go from illness and the focus on clinical indicators to patterns of living and the focus on quality of life. We go from doctor-patient relationship as the be-all and the end-all of healthcare, and we think about community and people-powered movements to enhance health. We go from data on individual events like a blood pressure reading to mass data, either mass data points across an individual's experience or across many individuals or both, as was described in the exciting presentation earlier this afternoon. We go from looking at the individual as the site of disease and as the locus of change to the individual as social, as situated. In Hillary Clinton's term from her book, It Takes a Village. We go from micro effects to macromolar effects and patterns of behavior. We're not interested so much in what the diabetic eats today. We're interested in what the diabetic eats over the 30 or 40 years that they live with diabetes. We go from main effects, looking for a unique and dominant effect of a single intervention, to recognizing complexity, that interactions are everywhere. For the statisticians in the room, the world is not orthogonal. Interactions and relationships are the order of the day. And we go from the energy from the individual to energy emerging from communities. And from a discussion earlier this morning, one line that I left out, we go from technical challenges to adaptive challenges and all the kinds of change techniques they go to. So I think that's a lot of what we're talking about, and I want to thank you very much. And don't forget, pick up from the Nesta table outside a little blurb on Peers for Progress. Thank you very much.
Thank you very much, Edwin. And I was very struck, as I always am, by that powerful statistic about the impact of isolation and loneliness on people's health and well-being. And again, a rather sobering conversation yesterday about some investment we made on enabling people with mental health problems to access work. And an example of a woman who had been to A&E 50 times in the last year, made myriad phone calls to 999 and turned up at the general practice at least 3 times a week, and actually had nuisance patient written on her records. Until someone thought about actually having a conversation with that woman about the kind of life she wanted to have, and had always wanted to work in a stable, and has now been enabled to be actually muck out at a stable and have social connection. And but the staggering, shocking thing is that it took that investment in that program to stimulate that piece of insight.
The wonderful intervention, I forget who talked about it this morning, I would love to learn more about it, of having volunteers trained to just sit with people who are alone in an emergency room.
Absolutely. No, I mean, many takeaways, aren't there, from today. I wonder, David, if I might turn to you first for kind of just reflect with us about what you've learned about the nature of incentives that you put into play in the kind of work around behavioural insights, because it's clear to me, having worked for a very long time in the kind of whole area of public service delivery, you can have incentives in play which are about performance, which can lead to gaming. And I think back to my experience around vocational skills and employment, where payment by results and getting people through qualifications, and people rating each other, and indeed in schools and league charts. And we know that over time an amount of gaming of the system emerges. So it seems important what the incentives are that you put in play, and just some of what you've learned through this work about that.
Yeah, well, obviously incentives do have some role, and so we're not saying conventional economics has nothing to do at all, but we just know from many other areas that lots of other things are in play, even in conventional labour markets. So what's more effective? Paying someone some extra reward because they're working hard and boost their productivity. In the short term, that does work, but normally for literally a few days, as opposed to giving someone feedback and just saying, hey, that was a great job you did. It's a smaller effect, but when you give a financial incentive, you tend to get an overswing, which knocks out the initial positive effect. So at the end of the week, they start working less than they were in between. So that just giving the verbal feedback is more powerful. By the way, giving them pizza as a reward is literally halfway in between. It's interesting.
Pizza, health.
But again, it goes to kind of, and we're learning this in relation to areas about economic growth and firm behaviour. I mean, a wonderful example of this is around Mike Norton's work from Harvard, where if you're going to give someone a very small financial incentive, he found a really effective thing to do is imagine you give someone a £50 reward. In many businesses, like, you did a great job, Edwin, here we are, here's $50. You'd be like, really? Thank you? You'd be offended. But it turns out if instead we give you that $50 and say, thank you so much for doing this, this $50 is to say to spend on someone else in your team. This is shown to significantly increase productivity and indeed well-being in a workplace. And why does that work? Well, first of all, people systematically underestimate how good it feels to give something away, which is a very nice result in its own. Secondly, it enhances communication running through an organisation. But the more fundamental point, I think, for health, and this is why you see the whole Linford result so powerfully that you mentioned, is that human beings are incredibly powerfully affected by, we're very social animals, by how other people are responding to us, which is one of the reasons why it's, we know the etiology really well about this, and that's the point about almost the giving side, is that giving makes you feel really good, particularly when someone else reciprocates, actually. And that's partly what lies behind the Norton work in the labour market, but it also is true why it is that, if you randomly give people a cold virus and stick them in hotels, what's the best predictor we've ever found? Not vitamin C, not any other drug treatment, is whether you can answer yes to the question, is there someone who loves you, who will help you if you need problems, right? If there was a drug that had anything like the effect sizes of this sort of pattern of mutual support, it would be the wonder drug of the century, right? And yet we're not very good at culturing that and utilising it, or fostering it as part of a healthcare system. It's crazy.
And the language of love doesn't appear much in public policy, does it, or in our day-to-day discourse? No, it's absolutely right. I mean, a lot of our work is love's work, actually, but it's not something that one conventionally talks about.
Just picking up on David's point, one of the most exciting observations we've had from Peers for Progress, a program in very poor rural Alabama with very low-income African-American people. We recruited peer supporters to work with others with diabetes, and the people who were running the intervention were reluctant to ask them to volunteer for more than 6 months, and the peer supporters were reluctant to sign on for more than 6 months. Once they got to 6 months, everybody said, oh, a year is no problem. The experience of learning skills where they actually feel they can be helpful to other people was incredibly reinforcing. And we've seen that in many, many other programs around the world, that people are very reinforced by taking on the role of being a peer supporter and feeling that there's something they can do that's constructive for others and for their community.
And I was just going to ask you a question about that, because I think you mentioned, we're all human beings. Gender doesn't necessarily have a part to play, men are from Mars and women are from Venus. But have you found any differences in terms of cross-culturally? I mean, I'll be honest, I work in a district which is hugely multicultural.
Sure.
The bonds of association and attachment are much stronger in some of my communities than, if I can say, in my white
Sure.
non-working communities, intergenerational non-working communities. How does that play out in your
I
work?
think there are a few things. We had a meeting a few years ago of our grantees and collaborators from a variety of countries, and a very intelligent professor from UCLA got up and said, let's face it, peer support programs are essentially programs for women. And half of the room jumped at her. I had to break up the fight. And in China, 67% of the men, all three of the people in that picture I showed you were men. 67% of the peer supporters in China are men, because older women still have family responsibilities and other things, retirees, and men have less, so that it tends to be more of a male role. So these things, the point is that we all benefit from having somebody who loves us or somebody we can call on for a favor and talk to about personal matters. But how we express it gets channeled by culture, by gender roles, and by all sorts of things. So that, David Beckham expresses his support for his peers differently than Lady Gaga. But we're all primates, and we all respond to this. I think there are cultural differences also in terms of middle class, well-educated, well-situated people can sort of get away with the myth of autonomy. People, cultures that have suffered and that have a lot of challenges tend to rely on each other more and be more explicit in their reliance on each other. We see it in medical practice. Pediatricians and gerontologists are very sensitive to social context. Adult internists may be insensitive to social context because they may see a lot of patients who are 50 years old and sort of on their own and can sort of pretend that they're autonomous. But you know, at both ends of the lifespan, we see the essential social rootedness of human behavior and health is in full bloom.
And that accepted, do you see in your work some of those kind of sensitivities and efficacy playing out in terms of different demographics?
A bit. I mean, by the way, often because of the way our situation is on data, a very technical detail but important one, we often aren't able to break things down in a very refined way. Look, is an issue which is particularly sharp in health, but in principle, we should be able to do a better job working out what works for who. But where the data is there, yes, you do see some of those differentials. They also apply at a higher level, so you see from a wider literature, say group effects, group density effects, they're so called. I mean, an elegant early test in the literature is that some more disadvantaged groups, which traditionally would be ethnic minorities, less so anymore, that if they're more clustered, you'd expect then you'd have worse health outcomes, where often you see better health outcomes. And it's because you can see this power of...
There's more social capital, actually, isn't there?
In the US now, we have tremendous influx of Latinos, and the Latinos get sicker as they come to the US and spend more time there.
Psychosocial impacts. Can we start to throw it open, I think, now for some questions? I'm just noticing time is running away from us. So we've got a lady over there in the kind of beigey green. Is that right? Are you beigey green? You'd like to tell us who you are and what your question is, and we'll take three maybe. There's one over there we'll go to after that.
I'm Madeline Starr from Carers UK. If we accept that being loved and being cared for is a really significant indicator in health outcomes, then, as we heard earlier, we actually have to begin factoring carers and families into the system and acknowledging that, and also understanding that the same is true of them, in particular with regard to peer support. So we know that where carers are not themselves supported, their health outcomes are likely to be twice as poor as for those who are supported or those who don't have caring responsibilities. So that kind of acknowledgement of what are human relationships, love relationships, even with their duty relationships, that's really powerful, but it has to be embedded in the system. And actually we very, very rarely include family in the system, let alone acknowledge that bond and the power and the positive outcomes that can come from that. And actually I would argue too that that's just as true for people who appear to be middle class and autonomous. These are bonds, and this is part of a human condition that I think is classless.
Okay, first question over there. Would you hold on to it? And we'll go across to this side of the room.
Hiya, I'm Laura. I'm from Club Soda. We help people change their drinking, whether they want to cut down, stop for a bit or quit. We're a behaviour change platform where peer support is the most important behaviour change tool we use. And we're looking at how we might build in a reward structure. I'm not convinced that gamification where people get points and rewards is ideal for adults, and whether what type of rewards or whether there is some framework in which you can look at rewards that will work within your peer support. I also have a question for David. We do some behaviour change work with pubs and bars on what they serve because our members always get pissed off about it. It's quite possible. The price point of premium soft drinks is one of the bars to pubs stocking them. If you put a sugar tax on, that will make a premium soft drink more expensive than an alcoholic drink. And we wonder if the Behavioural Insights team's doing any modelling around that. Because for our members, alcohol is about diet, it's not about addiction.
Great. Okay, and have we got a third question? We've got one down here, lady down here.
I'm Jabida Ali. I run Three Sisters Care. We're a domiciliary care agency. A question for David. You told us how not to tell someone they're fat, but I'd really like to know how to tell someone they're fat. Thank you, that would be very helpful.
Oh, that's great. Straight to the point. Maybe, David, you'd like to start with that first one, and then if I could just pick up, so we've got a question around behaviour change and drinking and problematic drinking and the kind of drinks industry, soft drinks pricing point. Got a question about embedding love, duty and support for carers into the whole system. But we'll start with, how do you tell someone they're fat in an appropriate manner?
Yeah, interesting. Because one of the things that happens if everyone else gets larger around you, let me use that word, you yourself, your perception changes, which is a really interesting phenomenon in its own right. I'm not sure I can remember the exact wording because it's obviously very critical as you've raised it, but Susan Jebb looked at this in some of this trial they were looking at. By the way, a lot of it was about also the effectiveness. It turns out that weight loss programs have been rather had too bad a press. I think they look like they're pretty promising, particularly in fact non-clinically based ones are very effective and even in short run. So there's good grounds why essentially clinicians should be prescribing weight loss programs and not be shy about it. It performs very well. Anyway, my main point is, maybe I'll come back to you on the specifics, but basically you want to work out wording which is fairly firm in terms of its direction of travel, that it might be helpful for you to go on this program, as opposed to asking a very general question to which the obvious answer will pop into your head, no, So, but it's a good challenge. Because partly our point would be, well, you can experiment with it, and you can help and you can support clinicians to give this kind of guidance in an effective way. I mean, there are lots of examples. Another one, which is people later in life, but clinicians seem to leave it very late to suggest you might want to move to more suitable accommodation. Yeah. And they're terrified of doing it, or they're terrified of having a conversation about end of life, right? Yeah. And one of the things we need to be trying to do with our clinicians is to be able to arm them with the ability to answer and engage in those sorts of questions with their patients, where actually the patients, if you do it sensitively, think it's entirely appropriate. But I mean, I don't know how many medical schools answer your question, right? And why not? They should be able to. Do you want to have a go at some of the other ones?
Yeah, I was just going to say it's not just clinicians that struggle with when's the right time for people as they grow old to move. I think families also struggle with it.
Just to put a log on the fire, the same issue emerges with, I didn't mean the pun, but I'm doing it, with cigarette smoking. Clinicians are afraid to talk to patients about quitting smoking, but the studies are that actually patients appreciate it because they take it as interest. They know they smoke, they know it's bad for you, and if the doctor ignores it, they assume the doctor doesn't care. My one advice would be not use the word fat. Talk about it could be helpful to your health if you could lose 10 pounds.
To pick up carers and families and how they're properly in the system.
So the study that David mentioned about the hotel room and the cold virus and being loved, actually an important part of that finding that sort of speaks to your point was that the best predictor of resistance to the virus was the diversity of social supports that people had. So friends, affiliations like church groups, as well as loving partner. And so I think that we need to think more diversely about all of this. And, I think it goes back to a big theme of today of communities and networks. The idea of a peer supporter sort of functioning autonomously out there in the world doing miracles is sort of nonsense. The peer supporter needs to be embedded. The notion, I don't want to be misunderstood. I'm not saying that middle-class, well-educated people don't need social support. What I was saying is that certainly in the States there's sort of a myth that some people don't need social support, and it's a myth. And in terms of alcohol, we've done a little bit of modeling, David, looking at social support and peer support as an economic substitute for the physiological effects of nicotine and alcohol. And so I would argue that probably peer support may be a better reinforcer than a lottery ticket for people who are learning to control their problem drinking.
Did you want to comment around the...
Yeah, very quickly on the carers one. It's such a critical. I mean, look, one of the great challenges of our age, I know Nesta is engaged in it, is exactly this question. So is Cabinet Office with the Social Action Team. Is how can you mobilise that support? I think there are lots of really interesting, promising examples, but we haven't really quite cracked it. We should admit, all of us, I think. So it ranges from the kind of Swedish patient hotels, where instead of saying to the patient the visiting hours are the following, designing a hospital which makes it easy for the relative to stay and be with them. What do you get? You get higher patient satisfaction, lower costs, and actually better clinical outcomes, right? Because you're actually training, supporting the relative or whatever. You think, why on earth wouldn't we design our system in that way? But how could we go further than that? Can I give you a personal example? I haven't given it for a while, but my youngest son, actually, when he was born, had essentially couldn't breathe. So he had tracheostomy for 4 years. And after 4 years of looking after his tracheostomy, my wife and I were pretty good at looking at it. I mean, the death rate from a tracheostomy, forget anything else, in a year is 1 in 20. So lots of things go wrong, get blocked or whatever, you get good at, and occasionally your 2-year-old pulls this thing out and you've got 2 minutes to get it fixed. And I was really struck. When he was 4.5, he was decannulated. And we said to the myriad of clinicians that we'd worked with, if there's another family and they need an evening off, because it's kind of stressful, we'd be really happy to do that, Were we ever asked? No, we were never asked. We almost think of our system, we worry about the legal issues, etc., etc. We had enormous goodwill and at that time quite a lot of experience on how to do that. Well, why wouldn't we design a system to do? But for more common issues, like which most of us, our capacity as human beings, can help each other. I walk past my elderly neighbour every day, and his wife has got quite severe dementia. And what could I do to help? Why can't we solve that problem to be able to enable people's goodwill to be able to support and help each other? And certainly Social Action Team Cabinet Office has funded a number of interventions, none of which have quite taken off, and certainly along the lines of, we were hoping, kind of like the Japanese Firikipu, the care ticket system, which would enable not just volunteering actually, but reciprocity to enable people to express that goodwill, partly an informational problem. So something like in that space is going to work sooner or later. Maybe you have good ideas what it would be, and we should all be desperately trying to figure out what that looks and feels like. Very briefly on drinks, I just say,
we'll come back.
Look, obviously we believe there are lots of other alternatives apart from lots of alcohol and lots of sugar, and we believe in the capacity of an inventive industry to come up with lots of alternatives. A purist view would be we only drink water, right? And what's interesting about the US market now, it's just partly about my consumer issue, is interesting. For example, we see massive innovation around flavoured teas. Flavoured teas have a lot less sugar in them than a lot of other sodas, right? And so the question is, can we create a set of incentives where people are able to savour and enjoy drinks and products which are essentially less bad for them, or it may even be good for them at the margin? I think there's lots of in that space.
Now, I'm aware we're going to run out of time.
Yep.
I'd quite like to go to Slido for a couple of questions, if I may. The top one here, I think this one is possibly firstly for you, David. How do we demystify behavioural change and enable frontline staff to use behavioural insights?
Well, we try and do that. We try to put a lot of our stuff in public domain. It's often simple mnemonics, things you can use. It turns into, for example, on the issue about how do you tell a larger patient what you might do, it's that it turns out actually quite concrete things about what's the right wording, what's the right thing to say, give a specific action that someone can use. So I think when a lot of people see the results, often in fact the reaction is, oh, that's kind of common sense. But for us, first of all, to see how powerful that can be, and that to unleash the capacity of many clinicians and others in the system to test variations and figure out what's more effective.
Can I take one for you? A different question, if I
Sure.
may, which is, I think I'll go down to Chris, which said, what's the evidence that online peer-to-peer support offers the same benefits as face-to-face peer support? So it's that kind of like, can you create really effective online peer support vis-a-vis actually the kind of face-to-face stuff?
So, and this gets back to your talk about how you can institutionalize asking your neighbor. The key issue, we know that peer support works. The key issues are understanding how to stage it, how to implement it, for whom, what kind, etc. And so we need to not think in terms of online in and of itself. It's online for whom and in what context, etc. So there's good evidence that online support can be effective. There's also some concern, actually, the one area where there seems to be some reliable evidence of iatrogenic effects of peer support is with unmoderated online support chats for people with serious diseases like advanced cancer. Makes perfect sense. Whereas for other things like people trying to quit smoking and things, online chats can probably be pretty good. And that leads, so we are very interested in learning more about how to stage peer support for different populations with different needs in different forms, mutual support, online, hybrid e-support, e-health and live peer support, face-to-face versus telephone, etc. I was curious, and you're working on trying to figure out how to provoke people into networks. My bet would be outside the health system is going to be more effective than within the health system, and I'm wondering whether that looks promising to you or not.
Well,
The doctors aren't set up to link you to other patients.
Well, that's a twist at the end. I guess our view would be, are we allowed to do this?
Go on.
Clinicians can ask certain questions and can enable it to have happen. So often someone with a chronic condition who's gone through similar experiences to you is going to be a very good person to talk to,
right.
At least for certain kinds of conditions. A clinician could certainly refer on and make some of those connections, and they could certainly make an ask to someone, would you be happy to help someone else? Remembering a lot of the points about the peer effects is that they flow to the person who's helping. I mean, that's what we see in general for mentoring.
That's
Often,
absolutely right.
typically, it's double
Giving.
the effect size to the mentor than the mentee. So clinicians can certainly design with that in mind to make these small asks and introductions and facilitate the growth of those groups. So it's sort of outside, but it's facilitated by the system itself.
Now
It's
then,
a hybrid.
Yeah.
we just got a hand shot up there. Looked like a person really, really wanted to ask a question. So we'll maybe make that the last question.
Mandy Rudzenko, carer for my son. It's all really interesting, but I actually feel really angry because there's no patient perspective here, and a lot of the things that you've said have really grated on my personal experience. What I want to know, how much patient perspective goes into this kind of research, and how do you think patients, if you're trying to tell somebody they're fat, they might think, well, I want to be fat, that's my choice. Is this about helping people or controlling people?
So great question to end on. Maybe both of you can reflect on that, and then we'll bring it to a close. I don't know who wants to go first. Patient perspective, where does it feature in all of this?
We try to build the patient perspective into peer support programs because frequently we're working with people who have the same problem, so it's implicit. In terms of control, I would go back to some fundamentals. I don't know whether you agree with this, David, or not, but control is inevitable. We are controlled. We are not free, but to bring our children up in a world that spends more marketing the single largest cause of avoidable death and disability, cigarettes, than any other product in the consumer space. We are not free but to see our children brought up in that world. So control is inevitable. The issue is whether we can recognize that control will happen and then try to harness control and influence for using democratic processes to guide it and for well-being and providing choice.
Yeah, so obviously I'm sorry if you feel that way, and that was probably my bad wording along the way, but our work throughout is very much built around the individual's experience, trying to understand it, almost ethnography as part of it in any given area, to understand the person's perspective. Indeed, one of the reasons why governments are pulled into this area in many ways is precisely because of that. It's because people end up pushed around by markets very often, being sold stuff, promoted stuff all around you. There's food, there's all kinds of other things being pushed at people. To understand it, well, what does it look and feel like from the individual? I gave the example on the missed appointments. If a hospital changes your appointment, you're much more likely then to not turn up at it, right? It's about respect and this kind of mutuality. So I think that is a key part of it. And certainly is an issue about trying to put control back into people's hands. And that's especially true when you go for this wider context. If you think about healthcare in a bigger area. So that's why I mentioned the example on obesity, is that can you turn the tables on the underlying dynamic? Our kids didn't choose to walk into every single store on the high street is pushing chocolate and candy at them, not just the supermarket anymore. And I personally think one of the lacuna in it is exactly as you mentioned, which is to introduce into policy making more essentially deliberative mechanisms, where you take a sample of the public themselves or the patients or whoever's being affected, and you say, well, what do you think deeply? You show them the evidence and you say, how would you like it to work? And so for some of the biggest successes in this area, they've been ultimately driven by that. And I'll just give you one closing one, which is that how are we able to change the defaults on pensions to move from an opt-in to an opt-out. It's been a game changer, more than 5 million more people saving. Who is it to decide which way that default goes? Incredibly consequential. The only reason why it was able to survive across administrations is there was a really, really good consultation by Adair Turner in this case, who kind of asked workers, what do you want to do, and showed the evidence. And they, in some sense, gave government the permission to make the change, not the other way around. And that should be true for many of these issues, particularly around lifestyle change, right? It's not, it's all our lifestyle change. We need to decide how we want that world to be around us, in my view.
So thank you, David, and thank you, Mandy, very much for bringing us right back to what is at the heart, really, of the debate for today, which is how we enable people to power their own lives and have the health and well-being we'd wish for ourselves and for everyone else. I'd like to thank both of you for a fantastic session. Thanks.